Our next speaker is Steven Fong, Dr. Steven Fong, gastroenterologist from Conquest Hospital, Hastings. He's going to talk about presentation and management of inflammatory bowel disease. Steve, over to you. Thank you for coming.
Thanks, Sam. I'll just share my screen in a second then. And can you guys let me know you can see this?
Yes, we can.
Brilliant. Well, I just want to say thank you. That was a really insightful presentation. We're going from one end of the spectrum now, from the hugely academic side to a very purely clinical side. So I've been asked to talk to you about how to manage acute IBD for the general medical registrar, or if you're a medical IMT or SHO, because this is a particularly important condition to really get to grips with. So my hope would be that you'll be able to learn how to manage acute colitis and acute Crohn's presentation as well after this presentation. I'll also give you a bit more of an idea about how to manage them in the era of COVID, which is where we are right now, and that is the reality. To my mind, this is the kind of triangle you're dealing with. You either manage both colitis or Crohn's, but you have to then put into account the fact that COVID can sometimes interfere with your plans. But I will hopefully try to convince you that that shouldn't necessarily change your plans completely. So it is a balance of risks and benefits about managing your inflammatory bowel disease as well as COVID. And over the next few slides, hopefully you'll get a much better idea of how that should be. Things that I think gets general medical registrars and SHOs a little bit anxious about are the fact that we have a big armory of medications and immunosuppressive treatments for the IBD, and that sometimes scares trainees about what to do. This is a timeline of what we had about 10 years ago, and back then it was very simple. You just had methotrexate, azathioprine, and steroids. But fast forward to this era, and you've got about 6 or 7 different biologics you could be using. But I think I want you to understand that just because there's a lot of different immunosuppressive medications, that doesn't necessarily change the management of the acute IBD presentation in a great way. So I don't want you to get distracted by the numerous medications. I still want you to focus on how to manage your patient when they rock up in A&E or in hospital. There are some things to understand about what IBDologists do. We do have, to a degree, a step up kind of thinking about our treatments, starting with the least aggressive treatments and then going on to steroids, mercaptopurine or azathioprine, and then biologics. So just having that rough idea that we are going up a treatment that is quite important as well. Now, there's no better way than to put this in your mind by going with a clinical case. So our first case here is a 35-year-old lady. She was diagnosed with ulcerative colitis about 5 years ago, and she's been very stable just on oral treatment with mesalazine. However, over a few weeks, she was started getting very bloody diarrhea, and she was opening her bowels 10 times a day. She called the IBD nurse and was started on steroids, prednisolone 40 milligrams once a day. But after 3 days, she didn't feel any improvement at all. She felt worse, so she was admitted to our acute assessment unit. So these are her overall clinical observations that I'd like you to just very gradually look through. She was slightly tachycardic, pulse of 105, slightly low blood pressure, but normal respiratory rate and good saturations on air. She wasn't breathless. She had a soft abdomen. There was no rebound tenderness or guarding. And these are her blood results. She had a hemoglobin of 103. She was anemic with a raised white cell count, normal lymphocyte count, normal renal function, lowish albumin, and a high CRP. Just say hypothetically, she's had a stool cultures which are negative and a negative COVID swab. So these are the results you have at hand, and let's just assume you're the medical registrar or the medical SHO seeing this patient. So you have a choice now. What do? Do you increase the steroids to 60 milligrams a day and say, let's get you home because, you know, the COVID rates are really high now, I don't want you to pick it up? Or B, should you admit the patient to hospital and start intravenous antibiotics? I mean, she's got raised white cell count. Do you admit her and start IV hydrocortisone? Or do you admit her to hospital and start a biologic such as infliximab? So maybe give yourself a few seconds to think through those options and think realistically, what would you do? Right, so next I'm going to give you the answer, which is, for me, in this setting, I would definitely admit this patient to hospital, and I would start that patient on IV hydrocortisone. Now, some of you might be saying, wait a minute, I mean, you know, is that really a safe thing to do, to give a immunosuppressive, especially for the rates of COVID that we have? And hopefully over the next few slides, I'm going to explain to you the rationale why option A is not such a good idea. And it all goes down to recognizing the signs to show you that this colitis is severe and needs a hospital admission. She's anemic, she's got low albumin, she's got high CRP, and she's a bit tachycardic, a bit hypotensive. These are all clues for you that you have to recognize on face value. It's also worth me also adding in that her chest X-ray is normal. So recognition is part of the key for medical doctors to know what to do with your ulcerative colitis. And some of you might be familiar with the True Love and Width score, which is a very simple scoring system to tell you whether it's mild, moderate, or severe colitis. And it generally, if it's severe, you have to start thinking about whether this patient needs to come into hospital. So in this case, this patient satisfies the severe category. She's got bloody stools more than 6 times a day. She's tachycardic. She doesn't have a temperature per se, but she's anemic and she has a very high CRP. So she fits a lot of the markers to say this lady is not someone you want to send home. What else were we looking for to give us an idea of how bad this is? So, I mean, this can look to people who are not familiar with endoscopic images as just a dog's dinner. But what I want you to maybe appreciate is as you go towards the right-hand side of the slide, the severity gets worse. And these are the 3 elements that we look at on endoscopy to tell us how bad the colitis is. One is the vascular pattern. If you have a normal bowel, your vascular pattern is quite apparent. But as the colitis gets worse, it all disappears. So you can see this is all blank. There's a lot more blood, so there's no blood here, a little bit of luminal blood, and here you've got lots of fresh blood in the bowel. And lastly, the degree of ulceration. Here you don't have really anything. Here you've got some erosions. Here's some superficial ulcerations. And here you've got some really deep ulcers. So really, the more you go to the right, things are getting bad. And so we use a urgent flexible sigmoidoscopy early on in admission to tell us what we're dealing with. And there's good correlation with the endoscopic scores and how bad it is with how bad the disease is. So I think one of the key messages here is getting an urgent flexible sigmoidoscopy early in acute colitis is a good idea. So moving forward, this patient was admitted to hospital and started on IV hydrocortisone. The abdominal X-ray didn't show a toxic megacolon, and a UCEIS score, which is a score we use for colitis, was quite high. So fast forward to day 3, and she's been on 3 days of intravenous hydrocortisone. She's still reporting rectal bleeding. So one question you need to ask yourself is, are you going to stop the Clexane? She's lost blood. Her bowel frequencies are down a bit, but her CRP is 45. So what are you going to do next? Are you going to refer her to the surgeons? Let's get a colectomy now. She is sick. Or maybe you're going to say, it's day 3, maybe give her a few more days of IV steroids. We might, turn the corner. Let's get started on the biologic. Or maybe you've heard about some fancy fecal transplants in a tertiary center. Or maybe you want to just recheck everything, like, maybe it is a infectious gastroenteritis. Let's check stool cultures. Could it be COVID related? Let's swab her. So give yourself a few seconds to think through this and what you want to do next. Now, if you had chosen start infliximab, then I think you've chosen the right answer. And for the sole reason, which I'll explain to you soon, is that it's all about following a very systematic algorithm or plan. Ulcerative colitis is not about winging it and just choosing something that's comfortable for you. This is the original British Society of Gastroenterology algorithm or pathway for managing acute severe ulcerative colitis, and this is freely available online to anyone who Googles it. So this is not something that you can't access. It is very easily available, and I strongly recommend you familiarize yourself as a medical registrar or as a medical SHO. The one difference is that with the event of COVID, that was modified slightly, and so the algorithm looks a little bit more messy, but actually, if you look at this very closely, not a lot has changed. You still give them steroids at day 1, and you get an urgent flexible sigmoidoscopy. So everything in green is things that a consensus panel has agreed is things we should still do. Things in red are things that we disagree with that you should change. Now, the crux here is understanding timescales. So this is not a patient that you leave on the medical assessment ward and check up on in 5 days hoping things are better. You need to have a set plan. If day 0 is, or day 1 is where you start the treatment, in 72 hours, you need to see where you are. If you've got someone with bowel motions more than 6 times a day, which this patient had, and a CRP of 45 and more, she is not responding to your steroids adequately. And there's a high risk that if we don't do something, she will need an operation. So you can see this is the crux here. You should have already actually got your surgeon involved from day 0, not because she needs the surgery straight away, but you're giving them a heads up. There's nothing worse, and I'm sure for medical registrars, nothing worse than getting a grumpy surgical registrar on day 3 and telling her that the patient is very sick and needs to be seen soon. They like to get the heads up early, even if they don't have to get involved straight away. But the crux is at day 3, we have to decide whether she's heading for surgery or whether you can benefit with a rescue therapy of infliximab. And so this is really day 3 is what I want to hammer into your heads. It is the day that you need to remember where you assess where you're going. Now, what happens next depends on totally where she responds. If she responds to steroids, to infliximab, she might not need surgery. If things don't improve, then we might need surgery. But the key here, which people do agree, is you should not be delaying a surgery purely for that status. If you have COVID, then you do have to get a COVID specialist. And it doesn't necessarily mean we change the plan. It depends on whether there is respiratory compromise. So really, the second take-home message is that you don't have to suddenly change everything just because you're worried about COVID. In this case, this patient had infliximab rescue therapy on day 3, and we carried on the hydrocortisone in parallel. She started improving 4 days after, and eventually by day 9, her CRP had gone down very well. She was changed to oral steroids, and 2 days later, we let her go home, and we got her next infusion in a few weeks' time, and the IBD nurses were well aware and seen her and arranged for the follow-up. So this is a good result, but this was dependent on following things very well. And inevitably, in certain places, if you don't do this right, you only see this patient at day 5. You might have delayed starting infliximab. She's quite unwell. She needs surgery. So I guess following a set algorithm is the key here. So a few take-home messages about ulcerative colitis is do not withhold steroids just because you're worried about COVID. You want to avoid it. Remember that the mortality from fulminant colitis is extremely high too. So at the risk of being scared of COVID, you may have subjected the patient to a worse outcome. And there is no strong evidence that IBD patients are increased risk of COVID at this time. So I think it's important that just because they're immunosuppressed does not mean the same thing as that they will get it. We still don't know if COVID will cause a relapse of IBD or whether it can cause new IBD. We've had some case reports that things have happened roughly the same time of getting COVID infection, and I've seen a few cases. But by itself, there isn't conclusive proof. So I think there's a lot more we still have to learn about COVID. And really, if you're in doubt as registrars, the BSG guidance on the management of acute ulcerative colitis is extremely useful, and I recommend you just Google it and have a look. So that's ulcerative colitis in the acute setting, and hopefully you've learned a few things from that. We're going to move on actually to a Crohn's case instead. This is an 18-year-old gentleman that I saw recently. He was misdiagnosed ulcerative colitis in a different hospital and somehow went off the radar, was not seen by anyone until he rocked up to the acute assessment unit. And on his abdomen, he had this small little pinpoint area, which was discharging some mucky mucus and pus. So any ideas what you think this could be? Well, this is essentially what we call enterocutaneous fistula, where the bowel is actually penetrated through, and it's because he's effectively not had ulcerative colitis, he's had Crohn's disease. He had a temperature, he was tachycardic, blood pressure was holding, and his SATs and everything were normal. He was a bit anemic for a young man with a raised white cell count and a very high CRP. And Sod's Law, his COVID swab was positive on admission, but he was not in any respiratory distress, and I'll say that out loud. He was not in respiratory distress. His chest X-ray was clear. Now, enterocutaneous fistulas are, one thing we can see with Crohn's disease. It's a slightly different entity from ulcerative colitis because it's a more penetrating disease. It's transmural, so it can go from the bowel straight through the skin, and this is effectively what's happened to this gentleman. Other ways it can present is with a mesenteric phlegmon, where you get is kind of a localized and contained abscess where the inflammation is. And the cases for Crohn's can be very tricky. They can be extremely complicated. So you have to now make a decision. What are you going to do in this case? Are you going to start this patient on IV steroids? Because I've told you that sometimes holding off immunosuppressive treatments can be worse. Will you put this patient on IV infliximab, or are you going to go straight for surgery? Or do you think this patient needs an IR-guided drain or IV antibiotics? So have a think about which of these you want to do. If you're chosen for IV antibiotics, I say that's really good. If the MRI or the CT shows a large abscess and he's getting worse, I might go for a drainage, but the IV antibiotics is the key here. And I definitely wouldn't go for steroids or surgery straight away, because this is a very different setting from ulcerative colitis. You've got an actual contained abscess probably. And so if you give IV biologics or steroids, you're likely to make him worse. We know there are poorer outcomes of surgery if you've got COVID. So especially if he wasn't severely septic and severely unwell despite not responding to IV antibiotics, I wouldn't rush into that either. So Crohn's management is different, and particularly I insist you also have a system for that, particularly if you're someone with, you've got enterocutaneous fistula. It's all about using the St. Mark's algorithm called SNAP, which is you've got to control your sepsis first. So strong IV antibiotics, you got to balance out your nutrition. And after that, you get scans to define what's the anatomy. And then you can plan properly whether he does need a procedure later. But you don't rush from here to the procedure until you sort these three out. So if you elaborate a bit more, it's about sorting out the infection. If it's a big abscess, you might need to drain it. You might put them on TPN or parenteral nutrition to give them some bowel rest, get the right imaging. That might include a CT or MRI or small bowel follow through. And then you plan really well. You take the time to do this properly. You don't rush it. This patient will start on TPN. We also gave him Modulin, which is a specially formulated enteral feed that is meant to be anti-inflammatory and gives them bowel rest, but also nutrition, and IV antibiotics. It's important you know your limits. So some things can't be managed in a district general hospital. You have to recognize that this is a very complex case. So essentially, we discussed it with our tertiary hospital and eventually transferred him there, where he had further scans. He had a few months of intravenous feeding before he was nutritionally replete, where his BMI was healthy, 21 instead of the underweight 40 BMI of 15 when he came in, and that's when you go for surgery. So you plan ahead. And he had a successful surgery with ileostomy formation. The enterocutaneous fistula was fixed, and he was discharged home and carried on with a biologic. And you can see throughout this case, no steroids were involved. And so what I'm trying to say to you, even though Crohn's and colitis are both parts of the same family, Crohn's is a bit more heterogeneous in its presentation. It can present with abscesses, strictures with obstruction or fistulas. So in this case, if it's an acute Crohn's presentation, I'm not as so much in a rush to start steroids. If the CRP is high, I'd consider cross-section of CTs to look for an abscess, and then maybe IV antibiotics. And once I know there's no abscess, I might consider steroids. So in this setting, it's a little less straightforward as you see. You need to decide your management based on the kind of presentation of Crohn's in front of you. And often dietetics input, nutritional assessment is very important, early input from your surgeons. And I always say to you, really find out what your IBD service in your hospital can provide, because, you know, in my trust, we have 4 IBD nurses with an email address for the IBD service. So it's always good to get those people involved early. And I recommend you as registrars or IMTs, ask yourself, what is the IBD setup in my hospital? Is it an email or phone number? Who's the consultant, gastro consultant who has an interest in IBD? Because then you can get them involved early when these patients present. The earlier we know about them, the earlier we can give you advice when they're complicated. So I would say refer to the BSG guidelines because they are very clear and very helpful in how to manage acute IBD. Remember, there are differences between ulcerative colitis and Crohn's. Some other common pitfalls: always do stool cultures. Don't forget the Clexane, because this is a population that is very high risk of PEs and DVTs. And involve your surgeons early, even if they don't have to start cutting straight away. Don't let COVID completely alter your management plan. So don't hold off steroids in the wrong setting, because acute IBD can be fatal as well. And with that, I really hope you've learned a few practical tips about how to manage acute IBD in this setting. And hopefully this is practical for you as medical registrars and IMT doctors. None of this is complicated rocket science. It's about doing things according to a system and not letting COVID get in the way and change your plans so much that you actually disadvantage your IBD patients. And number 2, always get your IBD team involved. Find out who they are and how you get involved. And I hope that helps. And that's the end of my presentation.
Thanks, Steve. Brilliant presentation. I can't see any more questions. There have been a couple of comments which were response to your questions in the talk. So let me have a look. Yeah, there's one question here. It says, I can find it tricky to be confident what to do if not scoring highly on potentially manageable as outpatient with escalation of usual therapy. Any advice?
It's a good question.
True love wits, that's what it is. Yeah,
absolutely. So the trick is True Love Wits is a guide, but as clinicians, you have to use your common sense, because let's just say your CRP isn't too high, but your patient is very tachycardic and a bit hypotensive. You probably still want to keep this patient in. And I would say that if you are thinking someone could go home, and if you're not sure, that's where getting your IBD service involved quite early on is really helpful. So you might send them home, but if you email our IBD nurses, they can hopefully call the patient the next day to see if they're doing well and do some monitoring at home. So it's that balance about using a score, but also your own common sense as a clinician, whether someone's really unwell or not. And if you know who to call in your IBD service, you might get an answer quite early on, actually. So I think using all those different resources will help you decide whether you need to manage someone as an outpatient or inpatient.
Okay, thank you. So another question, what would determine whether to go for CT or abdominal X-ray?
So Abdominal X-ray is very useful if you're worried about toxic megacolon ulcerative colitis. But if you have a Crohn's patient where you're worried that they've got a high CRP and they've got intra-abdominal abscess, then a CT is usually the way to go.
I can't see any more questions coming up. So thank you again, Steve.
Most welcome.
Okay, so next speaker is Dr. Mark Whitehead. He's